So let's get back to today's topic. Today we'll be talking about some chronic liver conditions which are medically and surgically important to be discussed. Why they are surgically important? Because ultimately they end up in liver cirrhosis, they end up in portal hypertension, and they end up in ascites. And we try to manage these conditions conservatively, medically, and taking a little bit of the help from the interventions. But ultimately, when the condition is worsening day by day, then you ultimately end up with the liver transplantation. So today we'll be talking about some of the chronic liver conditions. The important things we are going to discuss today is about the Chiari syndrome, primary sclerosing cholangitis, which is also to be important, chronic liver conditions. About the Chiari syndrome, it's basically the overall presentation, or the how the patient is going to present to you is abdominal ascites. And in case of the primary sclerosing cholangitis, the patient present to you with jaundice or abnormal liver function tests. There's another condition which is the primary biliary cirrhosis, and the symptoms, just like the primary sclerosing cholangitis, are non-specific, and the patient may present to you with a malaise, lethargy, itching, and abnormal LFTs as well. Another condition which is called as a Chiari disease, so it presents with abdominal pain, and sometimes the patient can be in sepsis, and there's some kind of the simple liver cysts which are usually the coincidental findings, and sometimes they can cause kind of a pain. And the polycystic liver diseases, and again, the patient present to you with a hepatomegaly. Now, we'll be discussing about these mentioned chronic liver conditions. About the Chiari syndrome, first you should know that actually what happens in a Chiari syndrome. So Chiari syndrome is particularly, it's a congenital defect, or you can say malfunctioning, and sometimes the people who develop the syndrome, they have some kind of tendency towards generalized thrombosis, and there's thrombosis in a hepatic vein, or there's a venous web occlusion, and because of that, there is an affected drainage, and there's the pooling, ultimately, and there's a hepatomegaly, and the patient presents to you with ascites. In case of the primary sclerosing cholangitis, as the name suggests, is the kind of the condition in which there is again a fibrosis. Sclerosing means there's extensive thickening, and there's a fibrosis of the parenchyma. And the cholangitis means they're related to the gallbladder, related to the bile ducts and the biliary channels, right? So primary sclerosing cholangitis, the patient present to you with the abnormal LFTs and obviously jaundice. Primary biliary cirrhosis is a type of another chronic liver condition, and we do not know exactly the mechanism behind this, but there is the cirrhosis of the biliary channels, and there is an effective, and the patient may present to you with obstructive jaundice, and there's a malaise, lethargy, itching, and abnormal liver function tests. Chiari disease is a kind of the disease in which there's a dilatation of the intrahepatic and extrahepatic channels, and the patient present to you with the abnormal abdominal pain, and sometimes the patient is in sepsis. They can be liver cysts, which can be simple, or they can be solitary cysts in the liver, and usually they do not cause any kind of the pain, but sometimes they also become painful like other cysts in the body, and it can be a coincidental finding. And the other disease is a polycystic kidney disease, which not only is related to the liver, but also it's usually whenever there's an adult polycystic kidney disease, the patient can have polycystic liver disease as well. And obviously the patient would be presenting to you with a hepatomegaly and sometimes pain. We'll be discussing these conditions one by one. So regarding the Bush-Chiari syndrome, this is, as you can appreciate in the diagram, this is the liver parenchyma, and these are the hepatic channels or the hepatic sinusoids or SNI, which are located inside this. And there's the hepatic vein, actually, which is draining the most of the the venous drainage comes to this. But in the Bush-Chiari syndrome, there can be a tendency towards thrombosis, or there can be multiple factors, but till now the research is mostly giving a kind of the clue that there is maybe protein C, protein S, or antithrombin 3 deficiency. So what happens in the Bush-Chiari syndrome is like the patient usually present to you with ascites or abnormal LFTs. So if you talk about the age group in which this Bush-Chiari syndrome is common, this is mostly affecting young females, and there is apparently or mechanically there is obstruction to the hepatic vein. So this obstruction can be because of the thrombosis, or there can be a venous web kind of the occlusion, which is effectively, causing ineffective drainage. So if you could appreciate in this diagram that these are the hepatic sinusoids, and they are ultimately draining into the hepatic vein, and the hepatic vein is ultimately entering into the portal vein, right? So what happens is like, if you could appreciate here in this diagram that if there is a kind of the occlusion here, then there would be a back pressure within the hepatic channels, and there would be a kind of the enlargement of the liver, a kind of the venous engorgement, and because of the venous engorgement, there would be hepatomegaly. And obviously, ultimately, the patient develops because of the obstruction to the hepatic vein, or in some cases, there is portal vein thrombosis as well. But typically, in the Bush-Chiari syndrome, there is hepatic vein thrombosis. So the patient will obviously present to you with the right hypochondrial pain sometimes, and ultimately, the patient can develop the portal hypertension. And because of the portal hypertension, the patient can present to you with ascites, which is the most common presentation of the Bush-Chiari syndrome. And when you actually investigate such a case, then you are coming up with a diagnosis of the Bush-Chiari syndrome. But usually, on the basis of the clinical symptoms, you cannot the symptoms cannot give you a clue about the Bush-Chiari syndrome, but the diagnosis can actually help you. So coming back to this topic we're discussing is about the Bush-Chiari syndrome. So what happens is like there's hepatic vein occlusion, and because of that there is back pressure because the venous drainage is being blocked, and there is dilatation of the veins which are present, hepatic veins, and the branches of tributaries coming into the hepatic vein, and ultimately there's engorgement in hepatomegaly and portal hypertension, and the patient present to you with ascites and sometimes variceal bleed as well. And if you are trying to investigate such a case, and then obviously the first thing you order is for the liver function test. And when you take the liver function test, then they are deranged in most of the time. Now, if we talk about the exact mechanism or exact cause behind the development of the Bush-Chiari syndrome, then most of the people think that there is some kind of the linkage with the protein C, protein S, or antithrombin 3 deficiency. So that's important when you are investigating such a case. Then you should also, other than a part you are investigating with the liver function test, you're investigating with a CT scan, but you should also investigate the protein C, protein S, and antithrombin 3 deficiency. But sometimes in advanced cases, the venous studies and the Doppler studies, they are sometimes important when you're discussing. So in the picture you can see in your screens is typically the CT scan of the abdomen, and it's a part of the liver. Actually, it's a segment of the liver, so you can appreciate that there is small dilatation, and because of the engorgement, there is parenchymal changes in the liver as well. So CT scan is going to give you a better diagnosis with the Chiari syndrome. So if you're done making the diagnosis, how actually you're going to treat. They can be acute conditions, or they can be chronic conditions. The presentation can be acute and the presentation can be chronic. So if the condition is acute and the patient is actually presenting to you with a fulminative hepatic failure, then obviously you have to put the patient on a supportive treatment. And you have to, when the patient is in fulminative hepatic failure, he can develop hepatic encephalopathy. And then obviously you have to put the patient on a conservative treatment, and you have to keep the patient in intensive care unit. But ultimately, you have to prepare the patient for the for the liver transplant. Why this is important? Because the fulminative hepatic failure doesn't give you a lot of time. It's only a matter of a few days, and the patient is gone by then. So it's important you vigorously or aggressively manage that patient on a conservative treatment. But you should also do the workup for their liver transplant if the patient is coming to you with hepatic fulminative failure. But there can be another conditions in which actually it's a liver failure, but hepatic functions are a little bit stable, and the patient is clinically stable. He is developing a kind of the failure, but the most of the parenchyma of the liver is not damaged by that time, or it is still functioning, and the functional capacity of the liver is not being compromised. So in that case, what you do is you do the angioplasty, or you place the stenting, or you remove the thrombus, actually, because the thrombus is causing the most of the problems. It's a arterial thrombus, or it's a venous thrombus, but actually you go for the angioplasties and you go for the stent placement. And in case of the chronic, there can be two conditions: one in which the hepatic function is being preserved, and one condition in which there is decompensated cirrhosis. So what you do is, in case of the preserved hepatic function, and still you just want to relieve the kind of the pressure over the liver, or you kind of try to give a symptomatic relief to the patient, and the parenchymal damage is not that extensive, then what you can do is you can put the portosystemic shunts, or you can place a transjugular intrahepatic portosystemic shunts. Or if the condition is in the decompensated cirrhosis, then obviously the liver transplant is the choice we have available with us. So always remember that Chiari syndrome, it can be either way. It can be acute or it can be chronic. So in acute condition, there can be fulminative hepatic failure. And we all know that fulminative hepatic failure is very bad, because ultimately there is a lot of pooling of the harmful nitrogenous waste products within the body. They cause the encephalopathy as well. So it should be treated aggressively in the intensive care unit, and you hydrate the patient, and you have to control the hepatic encephalopathy as well. Put the patient on the laxatives as well, and try to restore the liver function, or at least try to progress of the disease should be abandoned by the time you arrange the things for the liver transplantation. And there is another condition in acute in which the overall hepatic functions are stable. Then what you can do is you can give thrombolysis therapy to the patient. You can put the patient on some angioplastic stenting as well. And in the chronic, there can be compensated liver cirrhosis. There can be decompensated liver cirrhosis. So in case of the compensated, in which there is a preserved hepatic function, you can put the patient on a portosystemic shunts and manage the ascites, manage the portal hypertension, manage with the transjugular intrahepatic portosystemic shunts. And the other case in which already the decompensated cirrhosis is being developed, and what you can do is you can prepare the patient for the liver transplant, but by that time, keep the patient in a surgical unit, or at least place any kind of the stent, so that the overall, the morbidity can be affected, or at least it can give a kind of symptomatic relief to the patient. So this was about the Chiari syndrome. Always remember this is more common in the young females, and always think about that there is some kind of the myeloproliferative disorder, or there's a kind of the deficiency with the protein factors, maybe protein C, protein S, or antithrombin 3, which is responsible for the cause of this primary disorder. And then the management, and as much as the diagnosis and investigations are going to help you and make the diagnosis as soon as possible you can make it. Then there's another chronic liver condition which is called as a primary sclerosing cholangitis. Primary means we do not know the cause, but it's actually a congenital disease, and the process of the fibrosis, it's a kind of a tendency within that particular person or that particular patient to develop sclerosing cholangitis. And the only investigation that's going to help you is a cholangiogram. So, and about the primary sclerosing cholangitis, there is extensive fibrosis of the gallbladder, and sometimes there's a fibrosis of the biliary channels as well. And sometimes there is so much of the relationship. You can say it's a kind of dissociation. Primary sclerosing cholangitis incidence is 1 in 1 lakh, or almost 1 in 1 million of the population. What that means, 1 in 10 lakh, or 1 in 1 million of the population. So actually, it's important to discuss this topic because ultimately it's going to develop into there's a kind of association with the cholangiocarcinoma, right? So that's why it's important to diagnose and manage accordingly whatever the surgical option we have available and the condition of the patient. Secondly, it has got association with the ulcerative colitis. We do not know exactly what's the mechanism behind this, or why there is a kind of a predisposition, or it's a kind of the relationship between ulcerative colitis and primary sclerosing cholangitis. But it's seen the research and the cases, and it's seen that it's associated with ulcerative colitis. Those people who have inflammatory bowel disease, particularly the ulcerative colitis, they have a more tendency to develop primary sclerosing cholangitis. And by that means there's a fibrosis of the gallbladder, and there's an irregular, whenever you do the cholangiogram or whenever you do the CT scan, there would be irregular growth, or kind of the irregular parenchyma, or irregular morphology that would obviously, but we always know that on the background of the chronic fibrosis, there's a likelihood of the development of the carcinoma, right? So on the background of this chronic inflammatory or fibrosis phenomena, there's a chance to develop into the cholangiocarcinoma. So as there are no specific symptoms, in case of the primary sclerosing cholangitis, the patient actually can present to you with a jaundice or the deranged LFTs, and you try to investigate, and you order for the cholangiogram, and you ask for the association, or if he's a patient with inflammatory bowel disease, then you will think that there can be a primary sclerosing cholangitis. To be precisely, there's no specific treatment for the primary sclerosing cholangitis, and because of that, there is malfunctioning of the chronic fibrosis, and because of the malfunctioning, ultimately there is cholestasis, and the cholestasis, obviously the patient will present to you with the jaundice. In extensive cases, there can be the cholangiocarcinoma in extensive cases, and you need to order for the some biomarkers, and regarding the biomarker is a CA99. That means CA199, but CA199 is not very specific, because CA199 can be the tumor marker for the pancreatic carcinoma as well. But it's some kind of, in case of the cholangiocarcinoma, CA199 is also enhanced. But in this particular case, in which the cholangiocarcinoma is being developed at the background of the primary sclerosing cholangitis, then it becomes less sensitive, less specific, and usually CA199 is raised in almost 60% of the cases. But if you are trying to investigate a case of the cholangiocarcinoma without the background of the primary sclerosing cholangitis, then I would say there would be almost 90% specificity and the sensitivity of the CA199 as compared to the carcinoma, which is being developed on the background of the primary sclerosing cholangitis. So take-home message about the primary sclerosing cholangitis is like it's a chronic fibrosing condition. It's more common in the young adult group, and particularly the middle-aged men and the women as well. And most of the time, there is association with the ulcerative colitis, and those patients who has got ulcerative colitis or inflammatory bowel disease, there's 1 to 5% of the association with the primary sclerosing cholangitis. And if we talk about the incidence, 1 in 1 million or 1 in 1 lakh people are being affected by the primary sclerosing cholangitis. If we talk about the presentation, the patient will present to you with the jaundice or with the abnormal or the deranged liver function test. And then you talk about the investigation, then obviously the better investigation is a cholangiogram. And the other thing is the CT. It will tell you the architecture, the regular or irregular, wherever the chronic inflammatory process. So this is the diagram of the cholangiogram, and you can appreciate that these are the hepatic channels, and this is the gallbladder. And this is the cystic duct, which is coming from here, and it's combining with the common hepatic duct, and it's making the common bile duct, which is then obviously draining into the second part of the duodenum. But as you could see, there is a enhanced take-up of the contrast in this area, and there's an irregular morphology as well. So it's kind of giving you the indications, or the kind of giving you a clue about the primary sclerosing process. So non-specific symptoms and non-specific treatment, and if the patient presents to you with a cholestasis, and then obviously you have to tackle accordingly. And sometimes if we talk about the liver function test, then obviously ALP would be the most effective, which is the alkaline phosphatase, and it's coming from the biliary tract. So most of the time ALP is raised in case in which there's a full-blown development of the cholangiocarcinoma, then a CA199 would be enhanced in that particular case. And because in extensive cases there's a lot of the cholestasis, and because of that there is a pooling, and ultimately the patient develops the sepsis, and ultimately the patient dies. So talking about the cholangiocarcinoma, as you could see that it's a kind of the adenocarcinoma because the columnar epithelials, they're arising from the columnar epithelial cells. We talk about the GB epithelium. So the GB epithelium is the columnar epithelium, and particularly there would be, if we talk about the morphology of the patient, then obviously that would be cholangiocarcinoma, and there would be adenocarcinoma. And most of the time, it's not necessarily that all the patients who are developing the cholangiocarcinoma, they have a background of the primary sclerosing cholangitis, but since it's a chronic fibrosing inflammatory process, so we all know that actually on the background of the chronic fibrosis or the chronic inflammatory process, there's a tendency of developing a full-blown carcinoma. So the association is about 60%, almost 60% of the patient who has got primary sclerosing cholangitis, they develop a cholangiocarcinoma if not treated previously. And obviously, it depends upon the condition of the patient. Sometimes the whole of the, what you have to do is obviously you have to do the cholecystectomy, and sometimes some of the portion of the liver is being also resected. And sometimes when you are, you know, trying to differentiate between a cholangiocarcinoma, because on a CT, most of the time the appearance would be irregular, but you take the cytology, which is a brush cytology, which the good thing is, if you're trying to make a diagnosis, if it's a primary sclerosing cholangitis or full-blown carcinoma, then you need some kind of biopsy or a brush cytology. So what you do is you directly visualize through the endoscopy, or you take a brush cytology and the biopsy is being sent. Like you take the liver biopsy and being sent, and then they analyze the cytological smear and they identify the type of the cells which are being present. So you can appreciate on histopathological evidence that it's a full-blown carcinoma as it's a chronic fibrosing cholangitis. And as you could appreciate, this is the histopathological section, and this is the healthy parenchyma of the gallbladder, and this is the damage, or a kind of the metastatic or the malignant, indicating about the cholangiocarcinoma. And this is a kind of the when you are treating a case of the cholangiocarcinoma, what type of the incision you should give. It's called as a Mercedes-Benz sign. So it's a half Mercedes-Benz sign when you're trying to surgically resect that portion, some of the portion of the liver and with a gallbladder. Then what you do is you give it's a midline, it's a subcostal incision, and you're extending to the midline to the opposite side, and it's particularly called as a Mercedes incision, or it's a midline extended subcostal incision, and that's how you're going to resect or you're going to treat the patient. And obviously sometimes you need to put the patient on a radiotherapy and the chemotherapy as well. So there's another chronic liver condition which is called as primary biliary cirrhosis. So the name indicates that it's some kind of the cirrhotic phenomena which is going within the biliary channels, and starting from the intrahepatic to the extrahepatic biliary ducts or the biliary channels. And if we talk about exact mechanism or the pathophysiology behind this, we do not know the exact cause, but we know that there is a kind of the genetic phenomena, or there's some kind of the genetic predisposition of some people to develop the primary biliary cirrhosis. It's somehow similar to the primary sclerosing cholangitis in presentation, like they do not have the specific symptoms. There's the general malaise, there's lethargy, there can be pruritus, and pruritus can be, it's related to cirrhotic diseases, right? Like if it's a liver disease, liver cirrhosis, that's a cholangiocarcinoma, the patient presents to you with a pruritus. And if we investigate such a case, there's abnormal liver function test, but the bilirubin levels are disproportionate to the ALP levels. ALP, alkaline phosphatase, is more increased as compared to the bilirubin or the ALT. And the best thing, or the best investigation which is going to help you in making the diagnosis of a primary biliary cirrhosis, is circulating anti-smooth muscle antibodies. So actually, in case of the primary sclerosing cholangitis, the patient presents to you with obstructive jaundice. And in case of the primary biliary cirrhosis, again, there is some kind of the obstruction or some kind of the fibrosis which is already going on within the intrahepatic and the extrahepatic biliary channels, and the patient can actually present to you with a jaundice. Regarding the treatment, ultimately, you can manage patient conservatively if there's ascites, or you can place some kind of, because the patient is actually presenting to you with the obstructive jaundice. So how you are going to manage the obstructive jaundice? Obviously, you're gonna manage the ascites, and you're going to manage with a transhepatic, transjugular intrahepatic portosystemic shunts, which are the tips, or you can place some, by the percutaneous stenting. It can also be helpful. But in the advanced cases, ultimately the option you are available with is the liver transplantation. So, regarding the chronic liver condition, another condition which is common and which can be there is a Chiari disease. So if we talk about the Chiari disease, it's the dilatation of the intrahepatic and extrahepatic ducts, extrahepatic, intrahepatic biliary ducts. So what happens is, like, when there is dilatation of the intrahepatic and the extrahepatic duct, there's a stasis of the bile within those channels. So whenever there's a cholestasis or there's a stasis of the bile, there's a predisposition to form a stone. And the stone formation is within the liver or within the intrahepatic channels, which are already dilated. I ultimately compromise the functional status of the liver, and because of the compromise of the functional status of the liver, the patient can actually go into sepsis. So if you could appreciate is the diagram in case of the Chiari disease, and if you want to identify or you want to diagnose what the causative agent behind this is, you're going to order for the CT scan. Okay, so this is the CT scan, which is showing you this is the caudate lobe of the liver, and this is the other lobe of the liver, which is the mostly the left lobe of the liver. And you can appreciate here the spleen, and these are the common and hepatic bile duct, which are located within the Calyx triangle. So as you could appreciate, these are the intrahepatic ducts, right? And these dilated, you can appreciate in the liver, in the left lobe of the liver, that these are the dilated intrahepatic channels, right? And within these intrahepatic channels, there is stone formation within the hepatic sinusides or within the intrahepatic channels. And if you could appreciate that not only the intrahepatic and the Chiari disease, the intrahepatic channels are dilated, but sometimes the extrahepatic channels are also, dilated. But mostly the problem arises because of the dilatation in intrahepatic channels, and there's a stone formation. And in case when there's a stone formation, the patient can actually present to you with a sepsis. And whenever the patient is coming to you in a sepsis or in a condition which is acute, then you have to manage that particular condition accordingly, and you treat the patient under surviving septic guidelines, and you have to give a good antibiotic cover. You need to hydrate the patient, you need to monitor the input output, and you should shift that patient in an intensive care unit. So if we talk about the specific treatment, there are no specific treatment, but the channel, the hepatic channel, which is dilated, is and is causing a lot of the stone formation. So you do the partial or hepatectomy in particular case if you're dealing with a Chiari disease, and sometimes it's causing a lot of the other complications like the sepsis. So in case of the acute infective episodes and the patient is in sepsis, follow the surviving sepsis guidelines and shift the patient in the intensive care unit, give the good hydration status, maintain the oxygen saturation, maintain the fluid intake output, and try to manage this shocks, even try to manage the sepsis before the patient went into the shock. And other than that, good broad spectrum antibiotic therapy is good. Then if they're obstructive in the septic bile ducts, then obviously what you have to do is you have to drain them radiologically, or you have to drain them surgically. So for the radiological drainage, ERCP or percutaneously. So this is the option for those cases which have got the obstructive biliary ducts, or if the patient is in sepsis, obviously you need to follow the sepsis protocol, and you need to put the patient on good broad spectrum antibiotics. And obviously the carcinoma is, if it's like cholangiocarcinoma, then you have to treat the patient accordingly, and the option is obviously the resection. there's a segmental involvement. It's more, or it's like one of the segment of the part is involved. Then obviously there would be segmental involvement, in that you can go for the resection of that part, which is called the hepatectomy. And ultimately, the option we have available is a liver transplantation. Then talking about the cystic diseases of the liver, always remember that there can be two kinds of the cystic disease. One which are the part of the polycystic diseases, or some which are part of the solitary cysts which are present in the liver, right? So usually they do not cause any specific symptoms, but sometimes they can be painful, and it can be an incidental finding on ultrasound, or it can be incidental finding on a CT scan when you're investigating a case of the abdominal pain. And usually when you don't have to do anything with these cysts when the patient is not symptomatic. But when the patient is symptomatic, or it's causing a pain again and again, or there's a hemorrhage in the cyst, or it's a kind of the ruptured liver cyst, or because there is a tendency of rupture cyst or rupture hemorrhagic cyst to bleed, and the patient can go into the hypotensive or hypovolemic shock. Then obviously you have to manage on that lines. And it's kind of the surgical emergency when the cyst is already being ruptured, because the blood supply of the liver is profuse and it bleeds very badly. So it's important to go for the exploratory laparotomy whenever you're suspecting a rupture cyst or somehow like that. But in case of the simple cysts which are not symptomatic, then obviously you don't have to do anything. It's a kind of the incidental finding. So you can appreciate this is a CT scan of the abdomen, and it's the CT scan of the liver, and in the caudate lobe or the right lobe of the liver, there's a simple cyst, which is a large one. And if the patient is symptomatic, then obviously you don't have to do anything. But if the patient is symptomatic, then you have to go for the surgery. So talking about the indications for the surgery, if there's a rupture in the cyst, if there's a hemorrhage, or there is infection, or kind of the indeterminate diagnosis, or it's causing abdominal pain again and again, then obviously you need to go for that. But how do you proceed for surgery? Then obviously what you need to do is you need to give this right subcostal incision, or sometimes some people find it helpful to give the upper transverse incision. Whatever the incision you made, depending upon the location of the cyst, if it's in the caudate or the right lobe of the liver, it's involving the left lobe of the liver, obviously, that depends upon that. Then you expose that part and you de-roof, and obviously the wall of the liver is then de-roofed, and obviously you do the marsupialization of the liver. That means that you're inverting the cystic wall, and you are then suturing that with the wall of the liver. So that's how you de-roof such kind of the cysts which are present. Then there is another condition which is called as the polycystic liver disease. So always remember, the polycystic liver disease is in association with the polycystic kidney disease, and it's a kind of the autosomal dominant disorder, and it's somehow related to the genetic predisposition, and it's familial, and it's a part of the larger syndromes like adult polycystic kidney disease and association with the polycystic liver disease. So if the patient is symptomatic, obviously you don't need to do anything. But sometimes these polycystic liver disease, they become painful, and the patient present to you with a hepatomegaly. And obviously when you're trying to investigate such a case of the hepatomegaly, then you find out that the patient has got the polycystic kidney disease, the polycystic liver disease. Then obviously you need to go for the liver section, or a kind of the hepatectomy. If the involvement of the usually these polycystic liver diseases, these are not confined to one segment or one lobe, but usually they are involving diffusely the whole of the liver. So in that particular case, what you need to do is you need to take out that, and you need to go for the liver transplantation. And even if it's confined to to one specific segment, or if it's confined to one part of the one lobe of the liver, then obviously you do the lobectomy or you go for the hepatectomy. So you could appreciate in another CT, which is actually showing you that this is the left lobe of their liver, and it's a large cyst which is present on the left lobe of the liver. And these are multiple other cysts that you can say the hypoechoic lesion or the hypo dense lesions which are present here. So you can appreciate that these are also the different smaller cysts which are present in the liver. But if you the option is with you, you can resect the large cyst, or you can do the de-roofing or marsupialization. And if the hepatic function is being compromised, then you can go for that resection of that particular part of the liver. Then obviously that would be the choice depending upon the part, the lobe or the segment of the liver, and depending upon the functional status of the liver. So far we have discussed about the chronic liver conditions, we have discussed about the primary sclerosing cholangitis, we have discussed about the primary biliary cirrhosis and the Chiari syndrome. So always remember the chronic liver conditions. They ultimately, when they present to you with a portal hypertension, or they present to you with the ascites, or actually they present to you with a variceal bleeding, then obviously the management of the complications, and then ultimately you need to put the portosystemic shunts or the transhepatic, transjugular or intrahepatic portosystemic stenting can also be one of the kind of the interventional option we have available. But ultimately, you need to go for the liver transplantation, and some of the acute conditions like in the Chiari disease, and if there's a sepsis, then obviously you need to monitor the patient, and you need to follow the sepsis protocol for that acute infective episode. In case of the Chiari syndrome, there is a thrombosis, and obviously if there's an acute fulminative hepatic failure, then obviously you need to go for the liver transplantation. So that's all for today. I hope you enjoy this lecture and it's quite beneficial for you. Keep watching sqadia.com for other lectures.